So I am going to talk about universal newborn hearing screening and just kind of talk about several things that I feel like will probably clear up some issues. Okay, so today what I'm going to do is discuss some possible myths that are associated with universal newborn hearing screening training. My goal is to provide tips and resources for you to use in your hospitals with this, and to discuss some of my own research that I've actually conducted on universal newborn screening training. All right, so by a show of hands, who thinks that this on-the-job training for universal newborn hearing screening is sufficient? Anybody think it's true? Anybody think it's plausible? Anybody think it's false? I see some come on, interaction. So it would be false. Now, I am not going to discredit the hands-on training. That's a very, very key component, because you have to be able to know how to work the equipment, enter all the information, prep the baby, actually conduct the screening. So that is very, very critical. But a key component that we're missing is the background, the why. Why are we doing this? Why are we doing this universal newborn hearing screening? What could be the potential outcome if this child doesn't refer or doesn't pass? So we need to know why, and that's very, very important for our screeners. So let's talk about some of that background knowledge that is really important for screeners to know. Some hearing loss statistics. So 3 in every 1,000 babies born are born with hearing loss. And then for NICU babies, so for babies that end up in the NICU, 1 to 2 babies in 100 births are born with hearing loss. Now, there is some comorbidity with other things that go along with being in the NICU, having exposure to toxic meds, noise, the fact that they were born premature, could be they were deprived of some oxygen. So there are some other factors that also influence that statistic. But that's important to know that our NICU babies are high risk for developing hearing loss later in life. Something to know is that hearing loss is one of the #1 birth defects. And it's something that's not talked about a lot. So this slide is actually for 10,000 of congenital conditions. So when compared to other congenital birth conditions, it's easy to see that hearing loss is much more prevalent than many other birth defects that receive a great more deal of attention. Hearing loss is more like an invisible disability, because you don't see it. And so a lot of times it's not really talked about. So for example, of every 10,000 babies born, 30 will have permanent hearing loss, while only 11 will have Down syndrome, 5 will have spina bifida, and only 1 will have PKU. So this is why it's very critical that we are training our screeners and that they are doing a wonderful job with these screenings. So prior to universal newborn hearing screening, basically what we would do is we would only screen babies that had a high risk for hearing loss. So we had this high risk registry, and if they had a risk factor on that, then they were screened. Come to find out later on that most babies that are born with hearing loss have no family history. They have no risk factors. It's a spontaneous genetic mutation that happens. So we need to really know that we need to be screening everybody. And we also do need to know that we need to document if the child has risk factors. So when we're actually doing the newborn hearing screenings, we want to make sure that we're asking the parents, is there family history? Do they have any concerns? And then a whole list. And you can actually find this if you Google the document Joint Committee on Infant Hearing 2007. It has this whole list. But these are all of the different risk factors. And you will see that NICU has a great deal of risk factors. Okay, so what I want to spend a little bit of time on is some testing basics. So when we do universal newborn hearing screening, there are 2 ways to do it: the automated otoacoustic emissions or the automated auditory brainstem response testing. I'm going to focus on the automated brainstem response testing because many of the hospitals are using Peloton, and that company is using the AABR. And we have also heard that the Joint Committee on Infant Hearing are coming out with some new recommendations, and the recommendations are to do away with the automated OAE screening. And there's two reasons why. One is that it does have a higher initial refer rate, and the other is that it misses one particular type of hearing loss called auditory neuropathy. If a baby is born with auditory neuropathy, they will pass the automated OAE, where they will refer on the automated APR, which is why that's the gold standard for audiologists as well as for the NICU, because NICU babies are at higher risk. But still, the general population, we could be missing some of these babies. So I'm going to focus on this. So what it is doing is it's measuring the auditory nerve's response to sound. So just to kind of give you, this is the ear. So we have the outer ear, middle, inner ear. And when they hook up the baby to the AABR, they're going to scrub the forehead, behind the ears, put electrodes on, and then they're going to put the probe in the ear or little earmuffs that cover the pinna. The sound from the probe is going to go through that outer, middle, and inner ear and along the auditory neural pathway. The response is then picked up by those electrodes that have been placed on the baby's head, and the response is recorded and analyzed. And then the computer is going to give you whether it's a pass or a refer. I will mention that we like the term refer more than fail. All right, so continue on with our myths. I'm doing some training around it. What about this statement? A screening refer or fail is bad. So by show of hands, who thinks that's true? Who thinks it's plausible? Who thinks it's false? All right. That's right. So actually, these are pictures of my two children when they were having their universal newborn hearing screening, because I am an audiologist. So of course, I had my camera out for their universal newborn hearing screenings. My daughter is on the right, and she is actually a NICU graduate. So she was born at 29 weeks. So that's actually her first newborn hearing screening in the NICU. She ended up, right before we were discharged, had to have a round of gentamicin right before, so she ended up having to have a second universal newborn hearing screening. And then on the left is my son, and he was well baby. He was full term. So, but what I really want to illustrate, and this really needs to get home to anybody that's doing screenings, is that the goal of the screening is to identify the need for additional testing. It's not diagnosing hearing loss. Really, it's just a screening. It screens at one level. Just like if you were to go get a hearing screening at a community health fair, they screen at one level. The computer is screening the auditory nerve response at one level. And it's basically separating the babies that are more likely to have hearing loss than babies who don't. If we're going to be doing our jobs appropriately, then a small percentage of babies will refer on the screening, and that's okay, and we need to know that that's okay. Most of those babies that refer initially will go on to pass the diagnostic testing. So when they go to an audiologist, we do the diagnostic version of the auditory brainstem response to determine if there is hearing loss. And then at a small percentage of those babies who do refer, they are going to have hearing loss. And so it's critical for us to diagnose these babies early on so that we can get them into early intervention. These are our Eddie goals, the 1-3-6 rule. The critical age for developing speech and language is birth to 3 years. Whether that development is via audition, so they're going to be auditory verbal, or cochlear, with hearing aids or cochlear implants, or via American Sign Language. The big goal is to get them access to language, however that is, no matter what communication mode they use, is the access to language. And we need to get them that, which is why we need to identify hearing loss early. So our 1-3-6 goals are: we want to screen all babies by 1 month of age. We want to diagnose hearing loss by 3 months of age. So after we've done the initial screening at 1 month, we want to get them into the audiologist. We want to get them the diagnostic testing to find out, do they have hearing loss. and then intervention by 6 months. Intervention does not necessarily mean amplification. So if the child is born with profound hearing loss, I mean, no matter what amplification we would put on them, they don't have access to speech. It's going to be up to the family to decide what route do they want to go. Do they want their child to be auditory verbal? And if so, then the typical route is to get the child to see if they're a cochlear implant candidate and get them implanted. Or if they want to go into deaf culture and go with the American Sign Language route. Both choices are great, or maybe even a combination of both. The big thing is the access to language. And we know recent research is coming out, the 1-3-6 rule is working. So we know this works. Now, we've also seen where screeners, some have a tendency to want to get the babies to pass. They have this refer is negative, refer is bad. So if my baby refers when I'm doing this testing, that's bad. I need to screen until the baby passes. We actually know cases of babies that are being screened upwards of 17 times, one baby. Eventually a baby's going to pass. You're going to get a false pass. So what if you do that? What if I screen this baby until they finally pass? And what if that baby is in that small percentage that has hearing loss? What's going to happen to that child? Well, any degree of hearing loss is problematic. There's no good substitution for hearing. Even a mild hearing impairment can disrupt a child's development of speech and language. We know that auditory discrimination skills are associated with the development of basic academic competencies that are essential for successful educational performance. If a child cannot hear phonetic distinctions as early as his first year of life, he is at significant risk for language learning problems. So if a child cannot discriminate feet from eat, for example, he will not learn the appropriate semantic distinctions unless appropriate interventions occur. And that is if they are auditory verbal. Then if they go the route with American Sign Language, there is the focus of teaching American Sign Language and English at the same time so that their language and their reading skills are on par with everyone else. This is one of my favorite quotes. We speak because we hear, and we speak what we hear. So the impact on verbal language, again, this is going to be for somebody that is going to be auditory verbal. If a child has a prelingual severe or profound hearing impairment, the child will not learn speech unless intensive intervention occurs. If speech sounds are not clearly detected due to a more moderate hearing impairment or a fluctuation hearing impairment, a child's spoken language probably will not be clear either unless we have intervention that occurs. So even a mild, moderate, moderately severe, ones that when they are appropriately aided have access to speech, if they're not appropriately aided, we don't diagnose with hearing loss, that is going to affect their speech language development. There is going to affect their clarity, their intelligibility of speech. Also, we know that there is a big connection between learning speech and language and reading. If a child if they're not hearing clearly enough to identify word sound distinctions, then discrete verbal language concepts probably will not develop spontaneously. If verbal skills are spotty or deficient, reading skills are also likely to be deficient because reading is a secondary linguistic function built on speaking. If a child has poor reading skills, his academic options could be limited. We know literacy is linked to academics strongly. So this will cause just an unfortunate chain of events. So we want to get them, again, access to language, whether that is auditory verbal or through American Sign Language. Okay. So how do we help these screeners have these babies pass? So, if we're doing a good test environment, then if they, most likely, again, we want to keep our refer rate down, but we want the babies that refer because they are actually referring because of hearing loss, we want them to actually refer. So this is kind of the best practices to kind of help the screeners do the best screening possible. So the first is a quiet place to screen. So you want to make sure that if you're doing it in the mom's room or if you're doing the NICU, you've kind of taken them away from some of the machinery as best possible to try to eliminate some of the background noise. The other is, and post signs too, that screening is occurring. Inspect the ear to make sure the screening can occur, so it's free of debris, so you don't see any maybe afterbirth or wax or anything that could block the ear canal. You want a relaxed, sleeping baby. So this is going to help the myogenic noise, so muscle movement. Anything, if they're moving around, that's going to interfere with the machine's ability to actually analyze and pick up that recording from the auditory nerve. The baby should be well fed. If the baby is about to wake up to feed, this is not the time to do the screening, because the baby's going to wake up mad and they're going to be fussing, and then you're not going to be able to conduct the screening. So you want to make sure the baby's relaxed, sleeping, well fed. Baby should be comfortable and swaddled. Swaddled provides comfort to babies, as well as it keeps their hands away from any type of equipment. If a baby does refer, then we do want you to rescreen one other time before, if possible, before being discharged. However, we want you to wait at least 4 hours. And when they're rescreening, it's really evaluating the test condition. You know, was there something up with how they were testing to begin with? And remember, the screening is to find out babies that need additional testing, not to diagnose. All right, my last myth. A refer or fail happens because there's debris in the ear canal and it will clear up on its own. Is this true? Is it plausible? Is it false? This one's actually plausible. And this illustrates a point of why babies refer. So there are other reasons besides hearing loss that babies could refer, and we're going to talk about those. The baby is screened too soon after birth. So usually screenings occur the next day following birth, just to kind of let some of the afterbirth get out of the ear canals. If it's occurring too soon after birth, you still could have some afterbirth in the ear canal. Debris could be in the ear canal, or fluid. Fluid could actually have already developed in the middle ear space that could cause a refer. High impedance. So when we are doing the AABRs, you have to scrub the areas with electrode because you want good contact with the skin. If you have high impedance, then you're not going to get a good screening. Actually a tip that actually came from the company, the electrodes that are going to actually stick to the baby's head, if you are wearing a lab coat, put them in your pockets, and that actually, your body heat will actually warm them up and actually help them stick better. So just a little tip there. Myogenic noise, mentioned that's muscle movement. Any muscle movement can interfere with the machine's ability to pick up that recording from the auditory nerve. So we want to make sure, again, the baby's calm and relaxed. You can use a passy to help calm them down. However, there's a caveat to doing that. Sometimes babies suck so vigorously on the pacifier that it causes myogenic noise. So you just have to be mindful of that. And then electrical noise, that is more of an issue in the NICU just because there is so much machinery. Typically, babies that are being screened before discharge, so they're able to be off the monitors and be away from the monitors for a short period of time. So we recommend if you can get them away from the machinery, that would be best. If the screening is taking more than 12 to 15 minutes, then the recommendation is to stop and start troubleshooting. Is there an issue? What's going on? It should not be taking that long. Now this is key, communication with parents. We have to be careful on how we relay this information to parents when there is a refer. So Login 2013 actually interviewed many parents that had their children referred the newborn hearing screening and went on to have hearing impairment. And they found through these interviews that the screening experience was very, very important to them. They actually had very clear memories of the screening. Some of the things they said, they remembered that explanations were given for the refer result, that amniotic fluid may be in the middle ear, that the ear was too small, that the nurse themselves was having difficulty, or that the equipment, there's something wrong with the equipment, or it's just inconclusive. So the parents reported being reassured by that, an alternative to potentially having hearing loss. Now, granted, the screeners were not interviewed in this, so this is just one-sided from the parents, but it does illustrate of what a parent hears. So we need to be careful. Some aspects may have been told. Other things, other possible explanations were, again, maybe external noise or the equipment wasn't working. One parent reported that there were so many explanations that, of course, you embraced them. Being in quite a stressed situation. She points out at the time of having birth, she was just incapable of really even grasping the possibility that there was hearing loss. Parents also point out that there are many appointments in order to diagnose the child with hearing loss, and they felt like they should have been told earlier that this was a possibility. They felt like they were kind of falsely being reassured with that. So it's important for these screeners to be trained and that they be honest, and so not to tell a parent, oh, your child probably referred because there's debris or there's fluid in the middle ear. That's probably the most common thing we hear is fluid has already developed in the middle ear. Don't tell a parent that, because a parent hears, okay, it's probably nothing. So if they hear probably nothing, what happens? They don't go on to, they don't take the, they don't find it is so important to do the follow-up. And they may delay the follow-up. They may delay the follow-up 6 months, maybe a year, and maybe not until they actually start noticing a difference in what if that child does have hearing loss. So we don't want to pass that information on. We want to tell the parent that your child referred, and that it does not mean that they definitely have hearing loss. It means that we need to do additional testing to rule out hearing loss. So I said I wanted to get some resources. This is a great resource. So a lot of times, one of the big things is training is that really well baby and NICUs don't have the time to be able to really have somebody come in from the company and actually do like an all-day training or a morning training. It's hard to schedule that. We realize that. The National Center for Hearing Assessment Management designed an interactive web-based newborn hearing screening training curriculum. It's free. And some nurses can get CEUs for it. You can view it two ways. You can just view it where you go through the program without having to register, or you can register and take the pre and post test to potentially get CEUs. You can do this on your own time. You know, all hospitals, you have to do annual competencies. This is something that can be easily added within those competencies. And again, it's free, so definitely this is something that we really encourage you to use. Along with that, a lot of times screeners don't know how to answer questions. And so, again, that same website you can go to has all of these resources. It has frequently asked questions that screeners may have or may be asked by parents. It has scripts for telling the parents that they're going to screen. So sometimes maybe they don't know how to communicate that to the parent. They're going to come into the room and they're about to screen the hearing and they don't really know how to really talk to the parent about it. There's a script for that. There's even a script for if a parent says they refuse the screening. And you may think, why would a parent do that? Just like with everything, there's a lot of things going around on social media with parents. And actually, I remember quite vividly, there was one about a year ago talking about newborn screenings, like things that you could refuse when your child is born. And one of the things was universal newborn hearing screenings. And they were just talking about, and I remember how it went through that, no, it's not really invasive, but it's not really needed because you're going to be able to tell if your child's having hearing impairment. No. We know that actually how babbling and everything develops, some of that actually sounds just like a normal, typically developing child. It's not until later on in the months that you're going to start seeing the speech delay. So, what if it's mild hearing loss? Then your child will be answering. If you call them from another room, they'll probably answer you because it's very mild, but it's going to really start affecting their articulations, their intelligibility of speech, and it's going to start affecting their academics. So, and then there's scripts for communicating the results. So if a screener is not very comfortable on really how to articulate the results, there's scripts there. There's scripts for if they have a pass result. There's scripts for if the child passes but has high risk for hearing loss. This is going to be really important for our NICU. And this is something important. Even if the hospital uses the company Peloton, a lot of times the NICU nurses are still the ones conveying the results. And a lot of times parents will have a lot of questions because they are dealing with a lot. NICU parents deal with a lot of different information. And so this is still good for, even if the nurses are not doing the screenings, but maybe ask, then they can these trainings are great because they understand and can answer some of these questions that parents may have. More importantly, this is always the more uncomfortable conversation, is if the child refers. How am I going to tell this parent? I don't want to upset the parent, but I need to convey this information honestly. And so there's a screening there, and then there's a script for if they have a refer and they have a high risk for hearing loss. So, and it gives you, these scripts are not long, they're like a paragraph, but it gives them very clear instructions on how to communicate these results clearly to parents. So I think it's invaluable. And again, this is all free, it's on the website. And you can actually type in you can just type in National Center, the NCHAM website, or Google the interactive newborn hearing screening training. It'll bring you to the website, and then you can actually look for the scripts on there, and you can just download them and print them. All right. Then I'm going to talk a little bit, lastly, about some of the research that I have done. This one is already out, published, and it's open access, so you can actually search this, and if you want to know more about this research project. But a student and I, we surveyed parents of NICU graduates. We developed a 22-question survey, and we posted it on social media sites that are support groups for parents of preemies. So What to Expect When Expecting has a preemie group. There's several on Facebook. And what we were looking at is we wanted to know what information was being given to these NICU graduates. I know that when my daughter was discharged from the NICU, I was given a lot of information about heart follow-up, about vision, about developmental. But hearing was not one of those things that I was told about that she was at risk. Now, I'm an audiologist, so I know. I know that my child is at risk, as she has a hearing test every year. So I know that, and I knew I would get a letter from the state saying that she needed a follow-up testing. But that's because I'm in the field. What about other parents who do not know? And even the developmental screenings that are done, I know in Montgomery, hearing testing is not part of that. It's speech and occupational and other things, but hearing is not part of that. So we need to be passing that information along. We did get worldwide exposure because these were internet forums, so we actually had some international responses. We did have a state of Alabama bias, so a lot of the information I'm talking about actually is very relevant to our state. We actually had 272 surveys completed, but we only looked at the ones that were when children were born in 2007 until present, because a lot of things changed with the universal newborn hearing screening in 2007. Respondents were primarily from the United States, although we did have 17 international respondents from 5 different countries. Respondents indicated that nurses were the most common health professional who delivered the results, and they primarily related verbally. Further analysis of specific risk factors indicated that the 2 most prevalent risk factors for hearing loss in this population were prematurity, so born before 37 weeks, and a NICU stay of greater than 5 days. Now, we also wanted to know what the parents' awareness was. So were they aware that their child had risk factors for hearing loss because they were preemie? And we found that 41.7% and 12.7% respectively found that they really didn't really know very well that these were risk factors. So they didn't know that being premature put their child more at risk for hearing loss, or that having a NICU stay greater than 5 days put their child at risk for hearing loss. And here are some of the survey questions and some of the percentages that we have. Even though the majority of the respondents indicated their infants passed their newborn hearing screening, their lack of risk factor awareness is concerning because hearing loss can manifest months or even years later, and the timeline of identification can profoundly impact speech and language development. A study by Barrera Nelson in 2016 found that more than 1/3 of infants diagnosed with a progressive hearing loss had passed their initial newborn hearing screening, and that 28.5% developed a hearing loss after 6 months of age. So if parents are educated on this fact, they can be monitoring and can seek help earlier to prevent any of the negative consequences that we can see by delaying intervention. It also may be beneficial for parents to have the screening results included in discharge paperwork. So that was something that they need to have that in, and they also need to have milestones given to them. I know that Peloton automatically does that, but if hospitals are not using that, I don't know how widely that is used, but they do need to be giving that information to parents, especially in the NICU. So we do recommend that speech-language milestones be sent home in that paperwork. Information gathered from the survey adds a parent perspective to the newborn screening process, specifically the high-risk population, and it indicates the need to ensure information related to health and development of the children or recommended follow-up procedures are not missed. And then another one more relevant to the actual training procedures, we actually looked at using the program that I mentioned earlier. We surveyed nurses. Using that program, we did a survey pre and post, as well as the pre and post test within the actual system. And I kind of got interested in universal newborn screening training after my child was born in the NICU. Like I said, she had 2 universal newborn hearing screenings. The first one I was present for, the second one I wasn't, and so I was just so excited that she was getting discharged. So I saw that she had passed. I didn't really look at the paperwork. It wasn't until we got home and I was getting all her paperwork together in order to go to the pediatrician when I looked more carefully at her universal newborn hearing screening, and it had been checked pass with no risk factors. Child's a NICU baby. She has risk factors. And so that was something when I kind of got interested in what kind of training is going on in local hospitals and what can we do about it to just give the information and have the screeners know that they need to be passing this information on. So this present study was conducted to investigate the effectiveness of universal newborn hearing screening training provided to nursing professionals. And like I said, they did both objective and subjective. So the objective was the actual pre and post test within the program, and then we actually developed a survey that had questions just related to their comfort level and their knowledge level about universal newborn hearing screening. They completed the training program through the National Center for Hearing Assessment and Management. It was a group of licensed nurses, and they completed on their own. We found significant differences between pre and post test scores, so their test scores went up significantly going through the program. And we found significant differences for most of the pre and post test surveys. So the questions that we didn't find significant were more related to professional things of asking for help, things that other licensors would be comfortable with in the job setting. It was more things that were specifically related to the universal newborn hearing screening were the ones that were significantly different. Their comfort levels were improved. And that article will be coming out in October. Basically what our kind of takeaway from the research project was, in general, the findings of the study suggest that nursing professionals may not feel adequately up to date concerning administering and interpreting universal newborn hearing screening. Study participants who completed the specific online training made significant improvements. And it indicates that using that program is a successful way to train our screeners, nurses, physicians, whoever is doing the newborn hearing screenings. So we recommend this model should be considered to train professionals who are going to be doing the screenings. And additionally, continuing education should be included in the factors addressed in this model, such as how to complete the testing, what current equipment looks like, how to document and record results, and how to answer questions concerning the testing, which that program covers. The only part it does not cover is the hands-on component, which is still critical. So that's still going to be on the job, but at least the background part they can do as they need to, and can do it on their own time or break it up when they have a free moment. And again, it could be as part of the annual competencies they have to do for our hospital. We know that nurses are required to do CPR training every 2 years. That's something that we probably should be implementing this, especially for NICU nurses, so that they're aware of the hearing loss, the risk factors, and can be able to communicate this to the parents. And again, that's something we talk about when parents are discharged. They are overwhelmed with a lot of information, but hearing is just as important as the other information that they're getting. it can affect their lives just as much. And I do realize sometimes that is put on the back burner. There's more health considerations, but whenever they are able to go on and finish the follow-up testing. This is my contact information. I will be happy to be a resource for anyone that has any questions or wants additional information about universal newborn hearing screening or better ways to implement this. Again, feel free to contact me.